Hi there. I'm Dr. Aaron Weiner. I'm a licensed clinical psychologist and addiction specialist, and today we are here to talk about understanding and addressing alcohol misuse amongst your patients and some harm reduction strategies as well as treatment strategies that you can take as providers in order to help them be as healthy as possible, regardless of whether or not they're ready to discontinue use entirely. A couple of quick housekeeping items before we get underway. The first is that today's presentation is brought to you by the University of Arkansas Little Rock Mid-South Division and the University of Arkansas for Medical Sciences, Community Health, and Education Division. If you'd like to get in touch with me afterwards, if you have any questions about the presentation today, you are welcome to email me at aaron@weinerphd.com. My email is down there on the bottom left. So please, whenever you are watching this, feel free to drop me a line and I will be happy to provide primary sources, explain whatever would be helpful. So with that, let's go ahead and dive in because we just have a half an hour today and a lot we got to get through. So first, let's start with the broad view of what's going on right now with alcohol in terms of just numbers and how many folks are struggling. So in the United States right now, almost 53% of adults report past month drinking. And what's important about that is it's not everybody, certainly, but it is definitely a considerable amount. Now, just drinking alone isn't necessarily what we're concerned about as much from a health perspective, although we will talk about the implications of different levels of drinking in a minute. What really matters is binge drinking and alcohol use disorder. And right now, almost a quarter of adults report having binge drank in the past month, and almost or 11% rather, qualify for an alcohol use disorder in terms of what they are consuming. And those are the types of consumption patterns that we definitely are concerned about as providers because those have health implications. Now, in terms of, we'll call it the ultimate negative health implication, that being alcohol-related death, we're seeing some very concerning trends around that issue over time. If you look over the past 15, 20 years or so, we're unfortunately seeing this pretty consistent increase in alcohol-related death across our country, where the states that have the lowest increase is 15% increase, and some over doubling between 2007 and 2017. Where we stand right now is just a tremendous number of folks who have died from this. This is from the NIAAA, and depending on the metric that you look at, this one says 140,000 deaths. Another metric that we'll look at in a second says 180. But either way, it's a lot. And actually, if you put this in comparison to opioids in terms of the number of folks who are dealing with addiction and who have either acute or chronic related death due to alcohol, it dwarfs it, honestly. Yet we are not talking about an alcoholic epidemic. This is, of course, not taking anything away from the severity of the opioid epidemic, which is severe and important. And we tend to look the other way when it comes to alcohol, and we really shouldn't. Because there's a number of very significant health implications that come from the DSM-5 alcohol use disorder diagnosis. Now, as much as it's been increasing prior to COVID, actually COVID, we saw another jump in alcohol-related death of about 25% over the course of the pandemic, where when you look at the numbers in 2019, 2020, and 2021, kept going up and up and up. This mirrored actually what we saw with opioids. And so the number that we're seeing right now on the NIAAA's website, the National Institute of Alcoholism and Alcohol Abuse, is 178,000 deaths due to alcohol in 2021. That comes down to 488 deaths per day. It is the third leading cause of preventable death in the United States as a whole, and is a part of 40% of all driving fatalities. It is the most impactful human cause on this. 36 people are dying a day due to drunk drivers. 40% of all violent crime occurs under the influence of alcohol, 66% of domestic abuse cases, 50% of all sexual assaults. And if we look at it from a monetary perspective, almost $250 billion. The last time this data was crunched was in 2010, so a little bit outdated, but it was $250 billion. My hunch is it's probably even higher now. And you'll notice that part of that is due to healthcare. And that's because alcohol affects almost every part of the body you can imagine, from your brain to your stomach to your pancreas, to your bones, to your reproductive organs. It is, particularly when consumed chronically over time, an incredibly destructive substance. And so, with that as our backdrop, that it is actually causing a tremendous amount of healthcare burden and medical problems and physical and mental health problems across the country. And the question then that we've got to be thinking about as providers when we're working with someone, right? We've talked about the stats. Let's drill down now to the individual. Why does someone choose to do this? And again, we're talking about specifically the unhealthy drinking patterns. Why would someone do this on a regular basis in risky or unhealthy ways? Well, a lot of this comes down to coping. Because by and large, the reason why people are misusing alcohol is because they're using it to numb out feelings that they don't want to feel, to relax at the end of a day, to deal with trauma or grief, anxiety, whatever it is, it's serving an emotional purpose. And that is very important in terms of the calculus that someone goes through about will they or will they not do something. And if they're experiencing consequences and they're continuing to do it anyway, that means what they're getting must be extremely powerful to them. That whatever emotional purpose it's serving is very powerful. The way I like to think about this tension between our more logical side that would say, hey, maybe we shouldn't be drinking every day or drinking to intoxication every day. And the other part of us that says we don't want to feel discomfort right now, we should be drinking, is I like to imagine the brain under stress as like a dog driving an electric car, like a dog driving a Tesla. And here's why I like this analogy. Imagine, we're gonna break this down to a very simple dichotomy, but imagine that the brain has two somewhat conflictual components, where one part is the analytical side, that at the advanced side, that's the Tesla in this picture. That is our prefrontal cortex, where our executive functioning is housed. And that part of our brain is the part that allows us to do all of these higher level functions, right? To be able to synthesize big ideas, to think about long-term gain over short-term benefit, to moralize, to see the big picture. That part of our brain is what separates us from animals, but we have the animal brain as well. We have our limbic system, where our emotions and urges and drives come from. And what tends to happen, and if you look at fMRI studies, you'll see this, is that as you start to get more worked up, as you start to get more agitated, you see a decrease in activity in the prefrontal cortex as the limbic system starts to take over. And I like to call that the dog taking the wheel, getting behind the wheel of the car. And what our limbic system wants, what the dog behind the wheel of our car wants, is to not feel discomfort and pain. So there's like a strong hardwired survival mechanism where it says, I don't want to feel the way that I feel. And then it thinks, well, what can I do to escape from this feeling that I'm having? Well, that's where alcohol comes in, right? Because it can feel in the short term like a solution. You don't feel the emotional discomfort you were feeling before. Maybe you laugh, maybe you have a sense of release, maybe you have a sense of euphoria, which is something else that speaks directly to our limbic system. It loves to feel pleasure. If avoidance of pain and threat is the prime directive, the secondary is enhance pleasure and euphoria, positive feelings in the short term, like right now. And so that's, again, how alcohol tends to work its way in. Someone is feeling like they need it first, before, say, the physical addiction part kicks in with the with cravings, for example. But if we leave that part to the side for a second, where it starts to develop is someone feels like, I need to deal with my life somehow. I need to get through my days somehow. And alcohol is there. And it usually starts lower, you build up a tolerance, and it grows over time. But that daily use for coping is the heart of when you can conceptualize someone having a problem with alcohol. And I like to help patients think about this when they're deciding for themselves if they have a problem, because that is very important. You can't tell someone they have a problem and get them to do anything about it. They've got to decide this is an issue for themselves, and you can help lead them to that place where their relationship to alcohol is a problem. But the first element that I like to ask folks to think about is, what is the purpose behind your relationship to alcohol? And almost invariably, when it's becoming highly problematic for someone, the purpose is emotional. and more specifically to deal with problems. It's not about having fun. It's not just about socializing. It's about feeling okay, or sometimes avoiding withdrawal. If I don't have it, I'll go into withdrawal. So the first thing to think about is, why are you doing it? What's your purpose? Second is quantity. How much are you drinking? And sometimes there are specific amounts that are clearly a lot. Like if someone's, say, drinking like a fifth of something or an entire 12-pack in a night. But other times it can get a little bit tricky. So actually, I don't emphasize quantity as much unless someone is very clearly feeling like they're drinking a lot. Because it's very easy to look at someone else and say, well, I'm not drinking as much as them, so I must be okay. And that's another theme you'll see a lot. When folks are drinking quite a bit, they're either surrounded by people doing the same thing that they are, so it's been normalized for them, or they're alone and they're doing it on their own. But if they're around others who are also drinking heavily, they might not see their own use. They might not perceive their own use as being as significantly high as it actually is. The third aspect to look for is control. Can someone alter their use if they want to? Can they cut back? Can they discontinue? A lot of times folks will think that they can, but when they actually set their mind to it, it doesn't work out the way that they think it will. Quick note about this, though: if someone is testing control, if we're worried about withdrawal, we do not want to encourage them to just discontinue all alcohol use entirely, because depending on their level of use, they might then have acute withdrawal syndrome called delirium tremens, which can be fatal in some cases. So if we're worried at all about the experience of withdrawal, we want to encourage someone to get medical supervision, medical monitoring for that process. But short of something going from, again, drinking a considerable amount to drinking nothing, someone can try to cut back, see if it works, or try to stop, see if it works, or if it always seems to slide back to where it was before. And the fourth area I like to have folks think about are you having consequences due to your use, but still are doing it anyway? And these can be consequences to your bank account, to your weight, to your physical health, to your relationships, to your legal status, right? Like if you've driven drunk, any type of consequence, but you're still doing it. As I mentioned before in the previous slide, if you continue to do something that has clear negative consequences, that means you're getting something very powerful from it. Because for anything else, you'd probably be like, wow, this is actually pushing me further and further away from my partner or my children, or making things very difficult or tenuous at work, or whatever it is. Maybe my liver enzymes are elevated. Maybe I should change. If they're still doing it, that means they're getting something very powerful. It means that perhaps alcohol's role in their life has gotten to a point where it's unhealthy. So that brings us to the crux of this, though, which is, how can I help? From a medical perspective, what can we do? And we are going to talk about harm reduction today, but I'd like to nest it within the idea of SBIRT, because within a primary care setting, this is the gold standard for what you can do within that clinic visit. And SBIRT stands for screening, brief intervention, and referral to treatment. And we're going to run through this now from the perspective, again, of helping folks cut down on alcohol use. So screening means, are we detecting that there's a problem to begin with? And this is really important because a lot of times folks feel very hesitant to disclose. The screening form, which is, I think at this point, integrated into most EMRs, is the Audit C. And it's just a very quick, this is one form that I found for it. But these are the questions of just, how often have you had a drink containing alcohol? How many standard drinks containing alcohol do you have on a typical drinking day? And then how often do you have 4 or more drinks on one occasion? And there's options from 0 to 4 for each of these, depending on what they circle. And then you add it up. And depending on what somebody scores, that's either a positive or negative screen. So what's a positive screen? If you have a man taking this, if they score 4 or higher, that is considered a positive screen on the audit. If you have a woman taking it, if they score 3 or more, that's considered positive. And what that means is then you should follow up on it in the clinic visit. So ideally, someone would take this beforehand. They're in the waiting room, or they're, if they're doing, say, like a pre-check-in process on the EMR online, they fill it in there, so that then when they come in, and you see them, or when you come into the room, you can use this information in the visit. So how do you use the information? Well, sometimes it can feel a little bit awkward to bridge into it. And it's worth mentioning that both providers and patients oftentimes feel hesitant to talk about this subject. There's this feeling sometimes of shame and stigma that goes along with substance use or alcohol misuse. And so this very likely could be something that a patient wouldn't bring up unless prompted. And then even we've seen some studies showing that providers are less likely to bring it up as well because they don't feel comfortable. And so if you're looking for a way to open up about it, open the topic up, one way to do it is to fold it into, say, if you're doing an annual physical, other behavioral health related topics such as diet or exercise. So something like another factor that affects your health, or perhaps if there's some chronic health condition that someone's managing, is how much alcohol someone drinks. How would you say you tend to drink? Right? And that's a way to just open up the subject. You can also directly reference the screening materials if that's helpful. So I noticed that you mentioned in your paperwork that you've been drinking a few times a week. Do you mind if we talk a little bit about that? And so that hopefully then could get someone going in terms of telling you about what's going on. A quick little strategy tip I like to use: if you're assessing for quantity, you want to aim high with the query, because if you just ask, how many are you drinking in a week, or how many drinks do you have per drinking occasion, a lot of times folks will minimize because they feel a little bit sheepish about it. So if you aim high and say something like, so how much are we talking about? Like 10, 15 drinks a night? They'll go like, oh, no, just 8, or something like that. Or if it is 10 or 15, you'll have given them permission to say it because you've given them that higher number. So aiming high can sometimes get you a better result than just leaving it completely open. It normalizes it, it promotes honesty. So other alternative ways that you can ask about this topic are, how would you characterize your relationship with alcohol? It's asking someone like, how do you relate to it? What purpose does it serve for you? Or if you want to get at it a little bit more in a backdoor sort of way, if you want to be a little more passive at the outset, you can say, how do you like to deal with stress on a daily basis? And that could potentially be a way in. Also, not a bad question to ask just in general if we're talking about if we're doing an annual physical and we're taking stock of someone's health. That question is so key to mental and behavioral health. How do you deal with stress? You take stress in, you got to do something with it. You can't just sit with it. So you have to follow up from positive screens, though. We can't underscore that enough. There was a study that found actually that only about 48% of problem drinkers received a follow-up. And of these, most were told to just stop drinking. Like, you need to stop this. It'll be better for you if you stop. And only 2% in the study were referred for any specialty care. Ideally, we can bring that number up for those who it's actually indicated for, because specialty care can do a world of good. We'll talk more about what that is in a second. That said, the stop it method is incredibly time efficient, but not particularly efficacious. We find that just saying, don't do this anymore, doesn't actually get the job done. So the better approach here is you want to try to foster intrinsic motivation for follow-through through a brief intervention. And that's the second part of SBIRT. You got screening with the S, brief intervention is the BI. Now, when you're doing this brief intervention, motivational interviewing is the gold standard for how you conduct it. And so what MI is, MI for short, it's a research-backed approach to catalyze behavioral change. This is a fantastic book, Motivational Interviewing for Healthcare. Highly recommend to check it out if you're interested in diving deeper into this. But very briefly here, just to give you an idea of what this looks like. It's a collaborative approach to communication that promotes self-directed motivation for change. So this isn't you telling someone what they should do for their health. This is them saying they want to do it for their health, and you're helping them along that road. What you're doing is you're finding positive goals, their own motivation inside potentially some ambivalence, and you're enhancing their own motivation for change, oftentimes by developing discrepancy between where they are now and what they say they want. So if you have someone, say, who's drinking like 5, 6, 7 drinks a night, but then is also saying, but I want to be healthier. I want my longevity to be high. I know that it's having a negative impact on my life. What you're doing is you're trying to get that what's called cognitive dissonance, where your beliefs are pulling you in one direction, but your behaviors are pulling you in another. You want to try to enhance that, create more discomfort, so that ideally someone then decides, you know what, I should probably be changing my behaviors, and I'm interested in taking some steps to do that. These types of dialogues, though, should feel like dancing, not wrestling. So it's not like you're telling someone, oh, this is what you need to do, and this is what you need to do to make it better. It's more that you're asking a question and they're giving you a response. And I want to underscore, this does not have to take long. This can be, as we'll talk about in a slide or two, about 5 to 15 minutes, so very brief. So just to give you a couple examples of how this feels, say you've got a patient who says, I drink every night to let go of the stress from the day, but it's not a big deal because it's only 4 drinks, and I know other people who drink a lot more than I do. So, what you could say that would not be in this motivational interviewing philosophy approach would be something like, actually, 4 drinks a night is objectively a lot of alcohol to be drinking every day and is linked to a bunch of negative health outcomes. You'd be much better if you stopped and found another way to cope with your stress. Nothing factually incorrect about that statement, right? But that's you saying what you should do. A am I consistent response would be, it sounds like you don't feel that the nightly drinking is a problem for you. Has it been all positive, or has drinking caused any problems for you, like, say, with your family? And what that statement does is ask them, well, so is it causing any issues? And probably so, right? Like if you're having 4 drinks a night, like there's probably something cropping up. If not, it's just harder, of course, to motivate change. Still some levers we can pull, but a lot tougher. A lot of times, though, if someone is noticing a problem and they speak it, that goes a lot further than you saying what the problem is. One more example. Say you've got a patient who says, I keep having fights with my wife almost every day. It's really stressing me out, and she says things that make me feel awful about myself. I have to drink to deal with it. You could say, you should definitely try to get along better with your wife. The fighting is definitely fueling the drinking. What do you think you're doing that upsets her so much, right? Like just trying to say, well, okay, if that's the reason, why don't we just fix things with your wife and it's clearly your fault? Not helpful. Another option, it's so tough that you're fighting all the time with your wife. Have you resolved issues like this with her before? Right? So thinking about other ways to get at it, where in this case, maybe even pushing into the drinking wouldn't be useful. There might be pushback, right? I need this. My marriage is such an issue. Well, okay. Well, let's talk about ways that you've resolved things in the past, or maybe even offering options to help if they're interested. In terms of therapy, couples counseling, etc. So that's the more just overarching philosophy, right? We're not telling folks what to do. We're trying to get them to say what they want. But this brief intervention, it should be short, 5 to 15 minutes, and focus on motivation enhancement. So if someone's in a mild to moderate use state, we're just talking about maybe a behavior change on their part, and we'll talk about what harm reduction can look like. If it's more severe, we're thinking about helping them accept a referral to a specialty provider. And this is based on, motivational interviewing is based on the stages of change model over here on the right, where we're just trying to move someone along the path of motivation, which starts at pre-contemplation, which means someone isn't really even thinking about changing. Contemplation is they're thinking about changing, but they haven't made a decision to do it yet. Preparation is when you've decided you're going to change and you're getting ready to do it. You know you're going to do it, you're just getting ready. Action then is you are taking action to make the change in your life. And then maintenance is you've been in that action phase for a while and you're hardwiring it. And so what your goal is in a short period of time, you can't necessarily get someone from pre-contemplation to action or even contemplation to action. But if you can nudge them along and then have them come back, it can help a lot. Ways you can do this in a short amount of time are ask questions that enhance that cognitive dissonance, that highlight the downsides of use and the benefits of change. So things like, are there any downsides to drinking? Will anything get better if you stopped drinking? Questions like this, where you really try to help them think about, this isn't a good thing for me in my life. But instead of you saying that, again, they're the ones doing it. A great way to do this as well is through something called a readiness ruler, or just a ruler. You can do it with readiness or importance, something like that. So say we do this with importance. What the question would be is, on a scale of 0 to 10, how important is it to you to drink less? Where 0 is not very important and 10 is very important. The neat part about this sort of intervention is there's no wrong answer, because say they say 5, like it's a 5 out of 10 in terms of importance for them. Well, you could ask, okay, well, why a 5 and not a 2? And if you do that, they are going to tell you, even though it could be higher, right? It could be a 7, 8, 9, or 10. If you ask why a 5 and not a 2, they are going to tell you why it wasn't a 2, right? Why they think it's important to that 5 point. The other thing that you can do is ask, okay, well, what do you think it would take to bring you from a 5 to like an 8 in terms of the importance or their confidence in their ability to do it or their readiness? And then they'll tell you what needs to happen. Like, I think I need more support, or I think I need to know what the path forward is, or I think I might have to have it get worse before I'd want to change. Whatever it is, though, is what their truth is, at least as far as they understand it. And that's really helpful for you to know as a provider, because that helps you speak the language that they actually need to hear to achieve change. Ideally, you want to attain a commitment for an action, whatever that action is, if possible. But if not, that's okay. It can be a step-by-step process, but particularly if they're not hooked into care and they're willing to engage around the idea, make sure to schedule a follow-up. Because if they've disclosed this to you, if they're, say, having an alcohol problem, maybe they haven't to anybody else. And that puts you in a really powerful position to motivate change moving forward. So another way you can take the brief intervention, and again, clinical judgment on where you want to go with this, is educational, where people might not know the implications of what they're doing and where it could lead them. So you can help somebody understand, for example, what is your blood alcohol content getting to? Like, what does it mean if you are drinking 5, 6, 7 drinks a night? Some people might not even know what a standard drink is. And a lot of times folks actually undershoot it because they don't know how much a standard drink, say, of wine is, or how many drinks of wine are in a bottle, or what percentage of alcohol in a beer, a 12-ounce beer, constitutes one drink. So you can help them understand that more. And then any interactions they're having there with their health or their chronic health conditions, with any medications they're taking, because alcohol tends to impact a lot of different medications if you are drinking alcohol on a daily basis, particularly psychiatric ones. It can really make them not be as impactful as we'd like them to. The other thing that you can do, though, from, again, this harm reduction perspective, is you can talk about what low risk drinking guidelines are, and then how tolerance works, and then how over time, as someone drinks in a high risk way, they get closer to developing potentially an addiction, a chemical dependence to alcohol. And particularly if they have a family history of this puts them at risk. And so the way to frame this, if we're trying to approach this from again, a harm reduction model, how do we help people make lower risk decisions, is let them know what the interaction is between their biology and their choices, because ultimately that determines the outcome of someone's relationship with alcohol. There's a model of prevention called the lifestyle risk reduction model, which has been published on recently and was developed by the Prevention Research Institute, that talks about how if you let people know how their biology works around developing an addiction to alcohol, again, particularly with family history, and that they're at much greater risk of developing that dependency if they have that running in their family. But also that the way someone gets to problematic drinking behaviors is with their choices around consumption. If they make the choice to consume alcohol in a higher risk way, if they drink to intoxication over and over and over again, doing that frequently is what raises tolerance. And after a certain amount of tolerance, you hit what's called your trigger point, after which your body asks for the alcohol. And that trigger point tends to be lower for people who have a biological predisposition. And a lot of times, folks who have a biological predisposition for an alcohol addiction have a naturally higher tolerance, which brings them closer to hitting that point where their body would naturally ask for it. And so we don't know where that trigger point is until we hit it. But what we do know is that if you don't raise your tolerance up to that level, if you don't make those high risk choices, you're not going to hit that trigger point. And so that's the sort of education that we can give to folks around harm reduction. It's not necessarily that you don't have to drink. Sometimes that is the safest course depending on someone's risk factors, but they can decide whether or not they want to adhere to lower risk drinking guidelines. And what that looks like, and this is coming from Health Canada, and Canada is very forward thinking in terms of pushing out these alcohol related health guidelines. And so I'm going to steer us towards them for a quick second. The low risk drinking guidelines are 0 to 2 standard drinks per day for women and 0 to 3 standard drinks per day for men. And over the course of a week, no more than 10 standard drinks for women and 15 standard drinks for men. If someone adheres to that, they are very unlikely to develop an alcohol-related problem in their life. Doesn't mean that it can't happen, but that is a low-risk drinking guideline. If they are going over 2 or 3 standard drinks per day for women or men, and they're having more than 10 or 15 standard drinks per week, that's when we start to see more of these problems start to creep in. Doesn't mean that there are none. And we'll look at what those are in a second. But when we talk about what is a low-risk drinking guideline, this is what that looks like. Now, in terms of why we're talking about harm reduction. Abstinence, of course, can completely take out all alcohol related risk factors, right? If you're not putting any alcohol into your body, you're not causing any of the harms from it. However, a lot of times folks don't necessarily want to completely give up alcohol, even if it's in their best interest. And this actually can still be very useful, coming down and slowly decreasing. One way to think of it is what I'm calling reverse boiling frog syndrome. I think I ran into this somewhere in the literature, but boiling frog syndrome is when you're in a pot of water that's on the stove and it's slowly heating up. And so at a certain point, you're in boiling water, but because it's gone up 1 degree at a time, you don't notice that progression. And then it's like, oh my gosh, how did I get here? No, 1 degree at a time. But the backwards side of that, you can go in reverse and it works the same way. You can lower the temperature 1 degree at a time. You don't have to completely take the pot off the stove. You can, and that can be very good for health as well, right? If we take the metaphor away. But you can also lower the temperature, and that's what harm reduction is all about. And we've actually seen very favorable outcomes of doing this, of helping people reduce their drinking if they are not ready to eliminate it entirely. We see a lower risk of alcohol use disorders, improved mental health, lower blood pressure, better liver function. There are a lot of positive impacts we've seen of people reducing their alcohol use even if they don't eliminate it entirely. So don't let that perfect be the enemy of good here. Good is a decrease in all of these different areas, and any step towards health is a good step to take. Now, in terms of medications that you can use to help folks who are looking to make this sort of shift, there are several that have been approved by the FDA that can help either with harm reduction or with abstinence. However, despite the fact that we have 3 FDA-approved medications, actually only about 2% of individuals, or less, actually, depending on the studies that you look at, receive these medications. That to me seems low. Now, obviously, if someone doesn't want to use a medication, that's their prerogative. But when we think about how destructive this can be, how widespread use is, it seems like there's an opportunity here to educate patients on their options so that they can take them should they so choose. Now, here is a table of the medications, including these 3 that are FDA approved, as well as some that have had some research attention, but have not been FDA approved yet. The 3, though, that have been approved are disulfiram, naltrexone, and acamprosate, and they do slightly different things. The disulfiram, this would be used for folks interested in abstinence because it is not psychiatric medication at all. It affects the metabolism of alcohol, or more specifically acetaldehyde in the gut. And what it ends up doing functionally, though, is if someone drinks even a little bit, they're going to start vomiting very intensely. It's going to be this very hard boundary between them and drinking because it is so unpleasant to drink and so immediate. It will not take long before they are very violently vomiting, that they will not do it. And so if someone wants to not drink that day, they can take disulfiram, and that will accomplish that for them. But maybe they'll test it once, but not again. Someone still does have to take it, right? They still have to take the medication, but as long as they're taking it, that's a day that they won't be drinking. Naltrexone is more indicated for a harm reduction approach because what it does is it reduces cravings for alcohol, and it also decreases the euphoric effect that you experience when you drink. And so you're basically taking the reinforcement out of the drinking. You're not getting the positive benefits from it, even if you do drink. And so what we found is that people who are on naltrexone, if they drink, they tend to drink less. And for those who are trying to not drink at all, they have fewer cravings. And if they were to drink, they get less of that positive reinforcement, and it's easier to return back to that abstinence state. So that's what naltrexone does. Acamprosate is a craving reduction medication, and it does not there's no hepatic issues with it at all. It goes out through the kidneys. It goes through the renal system. And so if someone has some sort of compromised liver, compromised hepatic system, this gives you an alternative medication to prescribe that someone could use if they need to stop drinking, for example, but they can't take naltrexone. Acamprosate is another possibility for them. Now, if someone's in a position where they really just do need a referral to treatment, getting that specialty care is important and is very helpful. That said, the treatment recommendation should also account for the underlying cause as well as the use itself. So if someone's got depression, marital problems, anxiety, we got to make sure that we're addressing that as well. So in terms of options, just just very bare bones overview here, because ideally we're hooking someone into a behavioral health specialist to make these determinations. But if we don't have someone to help with that, we want to think about outpatient and inpatient options. Outpatient options involve potentially an individual therapist, intensive outpatient programs, or partial hospitalization programs. Both of those are outpatient. IOPs are about 3 hours a day, usually 5 days a week, sometimes a little bit less. PHPs are 6 hours a day, 5 days a week, and have integrated psychiatry, those sorts of things as part of them. Inpatient options include detox. So if someone needs medically monitored detox, that should be the first place they go. And then also residential options. So if someone needs to go away to kind of like your traditional rehab environment, where their chances of achieving their goals at home for whatever reason are lower, or they've tried outpatient and it hasn't worked, that's where the residential care facilities come in. If you're recommending someone to a program, I always recommend to watch for third-party accreditation, like Joint Commission, CARF, or COA. These are the top rated third-party accreditation groups, and most reputable programs have at least one of these, if not more than one, but at least one. One is also enough. Just make sure that one is there. And then peer support groups are also an option for someone who's looking to make a shift but might not have, say, a means for going to treatment or time. There are Alcoholics Anonymous groups that are all over the place and virtual. Smart recovery groups are going to be a little bit more tolerant of harm reduction goals. AA is really an abstinence-only environment. But smart recovery, absolutely. If someone is trying to change their relationship with alcohol but not discontinue that use entirely, they can get support along that journey from them as well. But just making sure if someone really needs that extra level of support, that's not just them doing it on their own or just with medication, that there are peer support groups, treatment options, lots of resources for them to tap into. So all that being said, to sum everything up from today, alcohol, it has actually, the use is very common, misuse and alcohol problems are also very common, and we don't, as a society, pay attention to it in probably the way that we really need to. And the use can turn into this maladaptive coping when we do it over and over and over again. Addictive substances are particularly attractive in times of high stress because it is this coping mechanism. And right now, in these post-COVID years, this is being recorded here in 2024, we know that stress, anxiety, depression are very high amongst adults. And youth alike, actually. Everyone has this very high emotional burden. The Esprit framework provides an effective method to prompt change, and that stands for screening, brief intervention, and referral to treatment. We want to make sure to screen folks, but then also to follow up. Be mindful of stigma and patient discomfort. People might not be volunteering this information if you don't ask and if you don't screen. We want to enhance their motivation for change, so get them to talk about why they want to change, what would be better if they were to change their relationship with alcohol. And it's very possible to do that in a short amount of time. Harm reduction specifically is a viable approach with alcohol. There are medications that can help with that. There are programs that people can go through that help them go, say, from 5 a night to 2 a night. Any step is a good step, because the less alcohol someone is consuming on a regular basis, the better it is for their physical and mental health. And lastly, know when and where to refer for additional care, because there might be some folks who need that additional layer, and if you don't know where to send them, that's tough, right? They might leave the office, not follow through. So if you can give them a number, a place where they can go, where they can call, and you know that they'll be in good hands, that is incredibly helpful to the patient and enhances that chance of follow through. So thank you all so much for your time and your attention to this program. Again, if you have any questions, please feel free to follow up with me at Aaron@WeinerPhD.com.